7, 8, 9, 10, 11, and 12.
Stop compressions. No pulse.
1, 2, and 3, and 4, and 5. 1, 2, and 3, and 4, and 5. 1, 2, and 3, and 4, and 5. Change 2, and 3, and 4, and 5.
You will be seeing a dramatization of a mock code in this program. Before the mock code begins, I would like to discuss its purpose. The mock code is a learning opportunity for nurses who may at some time be expected to perform professionally during a real cardiopulmonary arrest. This videotape, in conjunction with a written guide, can help you conduct mock codes on your nursing units. Thus, this program is to be used as an integral part of an educational program that prepares nurses to act responsibly and with certainty during a cardiopulmonary arrest. The mock code dramatization will be shown twice in this program. During the first showing, follow the sequence of events and be aware of the roles of the many participants. The second showing will include a narration, which emphasizes important details of the code. Finally, a summary will focus on specific responsibilities of floor nurses and review common emergency drugs used during the code.
Miss Jones, I have your pain medication for you. Miss Jones? Miss Jones? Oh my goodness, help! I am pushing the emergency button. I don't hear any breathing. I don't see any breathing. I don't feel any breathing. Code blue in room 310.
One, 2, 3, and 4, 5.
Did you
6,
call code?
7,
All right, I'll
8,
get the card.
9, 10, 11, and 12, 13, and 14, and 15. One, 2, and 3, and 4,
Have to put this
5,
under her?
6, and 7, and 8, 9, and 10, and 11, and 12, 13, and 14, and 15.
I heard the code. What else do you need here?
I'll need an ID.
I could use some help.
1, 2, and 3, and 4, 5, and 6, and 7, and 8, 9, 10, 11, and 12, 13, and 14, and 15.
Can you start this ID?
Sure.
1, 2, and 3, and 4, 5, and 6, and 7, and 8, 9, 10, 11, and 12.
Stop compressions. No pulse.
1, 2, and 3, and 4, and 5. 1, 2, and 3, and 4, and 5. 1, 2, and 3, and 4, and 5. Change 2, and 3, and 4, and 5.
There's no pulse. 1 and 2 and 3 and 4 and 5. 1 and 2 and 3 and 4 and 5. 1 and 2 and 3.
I have the ammo back,
4 and
please. There you
5.
go.
1 and 2 and 3 and 4 and 5. 1 and 2 and 3 and 4 and 5. 1 and 2 and 3 and 4 and 5.
Stop for a minute.
Nothing. What happened?
Well, this morning after breakfast, she complained of some indigestion, so I gave her some ginger ale, and she was doing fine, and I just came to give her a pain shot because she had surgery in her hip 2 days ago, and I found her non-responsive.
Let's see what we have on the monitor. A systole. Keep going. Do we have an IV? Yes, we do. Okay, let's give her 0.5 milligrams epinephrine IV push.
1 and 2 and 3 and 4 and 5. 1 and 2 and 3 and 4.
Let's get her
and
intubated.
5. 1 and 2 and 3 and 4 and 5. 1 and 2 and 3.
0.5 milligrams of epinephrine IV push.
0.5 milligrams of epinephrine IV push. Take over for me, please.
1 and 2 and 3 and 4 and 5. 1 and 2 and 3 and 4 and 5. 1 and 2 and 3 and 4 and 5. 1 and 2 and 3 and 4.
Hold it for a second. Okay, it's in.
Change in 2 and 3 and 4 and 5.
1 and 2 and 3 and 4 and 5. 1 and 2 and
Good
3
bilateral breath
four,
sounds. Give her 1
five,
milligram
2
atropine
and
IV push.
4 and 5. 1 and 2 and 3 and 4 and 5. 1 and 2 and 3 and 4 and 5. 1 and 2 and 3 and 4 and 5.
1 milligram of atropine IV push.
3 and
1
4
milligram
and
atropine
5.
IV
1,
push.
2 and 3.
You want to give me a syringe? I'll get some blood gases.
2, 3, 4, and 5. 1, and 2, and 3, 4, and 5. And 2, and 3, and 4, and 5. 1, and 2, and 3, and 4, and 5. 1, and 2, and 3.
Can you run this
4,
to the lab?
5. 1, and
How long
2,
since the epi?
3, 4, and 5.
4 minutes.
4 minutes, okay.
3, and 4, and 5. 1,
Wait a
and
minute.
2,
There's some electrical activity. Defibrillator, 200 watts.
4 and 5, 1 and 2 and 3 and 4 and 5, 1 and 2 and 3 and 4 and 5, 1 and 2 and 3 and 4 and 5.
Ready to defibrillate.
1,
Stand clear.
She's in VFib. No pulse. Defibrillator again. 300 watts.
5,
Ready to defibrillate. Stand clear.
Wait, she has a rhythm. Junctional tachycardia. She's got a pulse. What about a pressure?
60.
60. Okay, start her on her dopamine drip. 400 milligrams and 250 D5W. And start her at 5 mics. How much does she weigh?
£110 or 50 kilos.
Okay.
400 milligrams of dopamine and 250 D5W.
400 milligrams dopamine and 250 D5 and W.
And I'm going to start it at 5 mics.
Okay, 5 mics, I got it.
Any response?
There's no respiration.
Okay. She's having a lot of PVCs. Let's give her 50 milligrams of lidocaine.
Milligrams of lidocaine, IV push.
50 milligrams lidocaine, IV push.
Pulse is getting stronger. How about a pressure?
/90/60.
Good. Let's titrate the dopamine to maintain a pressure of 90 systolic. Any respirations?
Still no breathing.
Okay, keep bagging her. Let's get her to ICU.
You will notice that Resusci Annie has been placed in the room prior to the mock code. The code begins when nurse number 1 enters the room and finds her patient, Miss Jones, unresponsive. Since she's alone, she calls for help and pushes the emergency button. She opens the patient's airway and assesses breathing by listening, looking, and feeling. She immediately gives 2 full ventilations and palpates the carotid artery, establishing no pulse. She then simulates the activation of the code by dialing the emergency number and telling the operator the location of the arrest. Nurse number 2 enters, verifies that the code was called, and gets the crash cart. During this time, nurse number 1 continues one-person CPR at a 15-to-2 compression to ventilation ratio. Once the crash cart is in the room, nurse number 2 places the backboard under the patient. She then sets up the O2 to deliver 100% oxygen. She will also connect the suction and make sure it functions properly. When nurse number 3 responds to the emergency bell, she is told that an IV is needed. Help is also needed with CPR. She proceeds to set up the IV equipment.
Can you start this IV? Sure.
Since nurse number 2 is now free to start the line, nurse number 3 can assist with CPR. She assesses the adequacy of compressions by palpating the carotid artery. She asks nurse number 1 to stop in order to assess spontaneous cardiac activity.
No pulse.
Finding no pulse, nurse number 3 ventilates the patient. Now the compression to ventilation ratio is 5-to-1. CPR continues while nurse number 2 establishes the IV line for emergency drugs. Any certified floor nurse, IV therapist, ICU nurse, or MD may insert the line. As the floor nurses continue to manage the emergency, the code team will be responding. The team may consist of some or all of the following: an anesthesiologist, IV therapist, respiratory therapist, 1 or 2 ICU nurses, and a physician. In this case, an anesthesiologist has arrived and takes over ventilating the patient. The physician enters and listens for apical heart sounds.
Nothing. What happened?
Nurse number 1 tells how she found her patient.
Indigestion, so I gave her some ginger ale, and she was doing fine, and I just came to give her a pain shot because she had surgery in her hip 2 days
When the
ago,
ICU
and I
nurse
found her
enters,
non-responsive.
she immediately assesses cardiac rhythm with the quick look paddles. The rhythm is a systole.
Keep going. Do we have an IV?
Yes, we do.
The ICU nurse attaches the patient to the EKG monitor for continuous cardiac assessment. Since anesthesiology is monitoring the airway, one of the nurses is free to get needed equipment, monitor vital signs, assist with CPR, and generally help as needed. The first medication ordered was 0.5 milligrams of epinephrine to be given IV push. Intubation has been ordered. Compressions are stopped briefly to allow for visualization of the vocal cords and insertion of the tube.
Okay, it's in.
Proper tube placement is checked by listening to bilateral breath sounds.
1, 2, 3, 4, and 5. 1, 2, and
Good bilateral breath sounds. Give her 1 milligram atropine. IV push.
The second drug ordered is 1 milligram of atropine to be given IV push. As the ICU nurse gives the drug, she states, 1 milligram of atropine, IV push.
1 milligram of atropine, IV push.
1 milligram atropine, IV push.
Nurse number 2 acknowledges this by repeating the drug and the dosage. Notice throughout the code the direct line of communication between nurse number 2 and the ICU nurse. Arterial blood gases are now being drawn by the physician.
Can you run this to the lab? How long since the epi?
4 minutes.
The physician asks how long since the epinephrine was given. The response is in number of minutes, not actual time.
Electrical activity.
The physician sees some electrical activity on the monitor and orders defibrillation at 200 watt seconds. After preparing the equipment, the ICU nurse will apply the paddles to the chest wall, warn stand clear, and discharge the current.
Clear.
She's in VFib.
The resulting rhythm is ventricular fibrillation. Defibrillation is again ordered, this time at 300 watt seconds.
Wait, she has a rhythm. Junctional tachycardia.
The response is junctional tachycardia.
Blood pressure.
The patient has a palpable pulse, so compressions are stopped. Nurse number 3 checks the blood pressure and finds the patient hypotensive.
400 milligrams and 250 D5W.
The physician orders 400 milligrams of dopamine and 250 cc's of dextrose and water to be started at a rate of 5 micrograms per kilogram per minute. Nurse number 1 checks the chart for the patient's weight, which is 50 kilograms.
400 milligrams of dopamine and 250 D5W.
400 milligrams
Again, be aware of the direct line of communication between nurse number 2 and the ICU nurse.
I'm going to start it at 5 mics.
Okay, 5 mics, I got it.
Any response?
There's no respiration.
Since there are still no spontaneous respirations, anesthesiology continues to monitor the airway.
Milligrams of lidocaine.
The monitor shows frequent PVCs. The physician orders 50 milligrams of lidocaine IV push to suppress ventricular irritability.
50 milligrams of lidocaine, IV push.
50 milligrams lidocaine, IV push.
Pulse is getting stronger. How about
The pulse is getting stronger. The patient's blood pressure rises.
90 over 60.
The dopamine is then titrated to maintain a systolic pressure of 90.
Any respiration?
At this point, the patient has stabilized enough to be transferred to the ICU. Now that you have had an opportunity to view the mock code, let's summarize a few important points. Initially, patient management is the responsibility of floor nurses. This is a critical time for the patient, and correct, efficient CPR can be crucial to the patient's recovery. It is important that each person understand what priorities exist when an arrest occurs. Suction and oxygen must be set up and functioning properly. An IV line, if not already in place, should be established. All pertinent information, including drugs and changes in the EKG, must be documented on the resuscitation record. A line of communication needs to be clearly established between the nurse who is recording the information and the ICU nurse who is giving the medications. Now, let's review the medications used in our mock code. The first drug was epinephrine, which increases myocardial and central nervous system blood flow during CPR. The recommended dose is 0.5 to 1 milligram of a 1 to 10,000 solution given IV push. It may be repeated every 5 minutes. The second drug was atropine, which may be effective in treating ventricular asystole. The recommended dose for asystole is 1 milligram IV push. It may be repeated in 5 minutes. After resuscitation, dopamine was started to combat hypotension. The recommended initial dose is 2 to 5 micrograms per kilogram per minute. The infusion is then titrated to the desired effect. Dopamine is diluted in 5% dextrose and water and given by continuous drip, never IV push. The last drug was lidocaine, which is the drug of choice for ventricular ectopy. The drug may be given IV push and by continuous drip. The initial dose is 1 milligram per kilogram, given IV push. This completes our review of the medications. We suggest you practice mock codes on your own nursing units and hope this program has shown you how knowledge, practice, and good communication can affect patient care in a cardiopulmonary arrest.